And our next speaker, as a part of our innovation segment for this symposia, will be Dr. Georges Chabouh, who is a biomedical imaging researcher at Resolve Stroke, developing user-independent ultrasound technologies to monitor cerebral perfusion in stroke care.
Yeah, thank you so
Thank
much
you
for the
for joining.
introduction. Thank you for the invitation, Dr. Sarwa, as well. So my name is George Chabouh. I am presenting the work that we've been doing at Resolve Stroke startup in Paris, in France. And it's about a novel user-independent ultrasound for monitoring of cerebral perfusion. These are my disclosures. So as you know, transcranial TCD has many limitations, as Dr. Chu just nicely introduced. So mainly the first one would be the fact that is user dependent. So it needs a lot of training. The physician or even the sonographer need to place the probe on the current plane. And this leads actually to the second limitation, which is actually the out of plane flow and out of plane motion. As you may know, our organs are in 3D, so it's really important to be every time placed on the same slice in order to get reliable quantification. So. And this is actually due to what's happening today in the clinic is the way the image are formed, which is the conventional echography, which is actually based on line by line scan. So when we do this, we have to send the waves, receive on one line, reconstruct the image, and get a very low frame rate. So our technology is actually also using volumetric ultrafast echography. And with this way, the probe is actually sending diverging waves with a big field of view. And this is exactly where we elevate the user dependency. So we do not need to be exactly placed on the good plane. We just have to place the probe on the temporal bone. And then with this large field of view, we are sure to get the whole field of view. And this volume rate is actually high enough, so we could actually see very slow phenomenon and actually very small vessels. Apart from user dependency, there is many things we can do in ultrasound, as we saw in the early presentation. One of them is actually perfusion. So if we look at what in cardiology or in nephrology they're doing, they do perfusion. So it's actually relied on the fact that they inject microbubbles or ultrasound contrast agents, which are tiny little bubbles that are encapsulated with a thin shell. They are FDA approved as well as in Europe. So the one known is Sonoview in Europe and Definity in the US. And with this, actually, we could get a map of perfusion in the organ. So the question is, what about neurology? Why could we not also have a nice morphology, not only from the bone perspective, but also from the vessels? And also, why could we not get perfusion? Why do we have to always go to the CT? And of course, we could just use how the ultrasound are safe, can use bedside, cheap, repeatable. So it shouldn't be that hard. So we suggest that 3D contrast enhanced ultrasound can be the solution. So we built our device, which is the one that you see here on the right side. So it's a normal echograph that you actually use today. Here you can see the probe is as any probe, familiar with what you've been using so far. And just by placing the probe on the temporal bone, injecting one bolus of microbubbles and hit run, then you're actually good to go. So the workflow looks like this. You indeed bring the ultrasound, our silver platform, next to the patient. You have to find an anatomical structure with our high resolution B mode. And then you have to administer the microbubbles. And then in only 5 minutes, you can get on both sides offline a comprehensive report. So everything is in the software. So after just 5 minutes, you remove the probe and you can access to our software where you can get 3 different modes that I'm gonna show later, which is perfusion, microvascular, and velocity. And more importantly, you could just do this longitudinally, so you can follow up your patient. And the fact that it's done in 3D, there is an automatic registration of the anatomy so that the everyday follow-up is actually accurate. So the first mode that I'm going to show today is the microvasculature imaging mode. So it provides 3D microvascular anatomy. So if you look at this right side, 3D slice by slice animation, you could actually start to recognize all the vessels. So if I take a little pause here, you can basically start to see here the Willis circle. You can see the MCA going up. You can see the posterior communicating artery, the anterior communicating artery, and even the basilar artery. And we can also see tiny little vessels up here in the cortex. So on the left side, other examples on other patients with another view, which is only 2D slice, and we can actually appreciate the level of details in our image. The second mode I'm going to show you is the 4D flow, which is offline Doppler velocity quantification. So as you may know, today transcranial Doppler is done during the acquisition. So the physician, the sonographer, has to do the acquisition, and then during the exam get the quantification. What's different here is basically you inject the microbubbles, acquire the data, and then at the post-processing, you can get the whole field of view in 3D, and you can actually check at each point of your vessel what is your Doppler spectrum or velocity. So this is an interesting example I want to share with you today on the left side. It's a patient who got a vasospasm stenosis here, as you can see morphologically on the vessel. So we're not anymore just listening to the vasospasm, we're actually seeing the vasospasm. So you can, for instance, get the resistivity index map, and it clearly show high resistivity here in the middle, in the location of the spasm, and it's actually showing high velocities in this region. And the third mode, and the most important one, is what I said before, the perfusion. So once you inject those microbubbles, the contrast agents, you can actually start to see the enhancement only in the large arteries, as you can see here on the MCA, for instance, and then slowly those microbubbles will travel up to the arterioles and then the capillary beds and then give a perfusion in the whole tissue. You can get a quantification on the time intensity enhancement curve, as you can see here. And then by differentiating the time of arrival in the arteries from the time of arrivals in the tissue, you could get, for instance, a Tmax or time to peak map, as you can see on this side, which is exactly what you can get from CT perfusion. So all in all, you can get cerebral blood flow quantification bedside with this technology. We're actually seeing a concordance of our ultrasound perfusion with the CT perfusion. So you can see here clearly how both sides, ultrasound acquisition, they are well corresponding to visually to the Tmax that we could get from raw data CT scans, CT perfusion. So let's quickly go to the clinical trial that we've done. So it was in aneurysmal subarachnoid hemorrhage in France in the neuro ICU. It was 11 patients where we did the 66 acquisitions. So it's 3 time points left and right. And first, what we saw is basically 95% of those acquisition were successful, which means when I said user independent is basically we did not have trained physician or trained sonographer who've done the acquisition. So in 95% of the case, we managed to see all the major arteries and even sometimes MCA 2 plus bifurcations. The only 5% remaining patients or acquisition were having a very altered perfusion and were almost near encephalic death. As I said, we monitored those patients since the admission at day 0 and then at day 5 and 10, which basically where it's critical and vasospasm may occur, and until day 11 to 15, so 3 time points. And for instance, in this example, we had a favorable evolution, so the patient actually got better, no neurological deficit, and no vasospasm. On the other side, sometimes we could also get unfavorable outcome. So I want to share with you the story of this patient quickly, where we detected delayed cerebral ischemia before the clinical onset. So this patient was on admission for aneurysmal subarachnoid hemorrhage, got coiling, and then at day 3, we performed our ultrasound perfusion imaging. And as you can see here, oops, we could see clearly how the left side has abnormal perfusion, so there is heterogeneity in the map, and the time intensity curve is actually widespread and coming later. So abnormal perfusion, and at the same time, at day 4, this patient is having a spasm on the right side. So there is a spasm on the right side, and we're seeing abnormal perfusion on the left side. And then at day 5, this patient got a delayed cerebral ischemia because he had a right hemiplegia, which actually confirms that the problem was happening on the left side. And this is what we saw on day 6 with the infarctus here on the non-contrast CT. So the take-home message from this slide would be sometimes the vasospasm can be occurring on one side, but the actual problem of perfusion, where we got the ischemia, could be on the other side, and it was not possible to see this at bedside without this technology. So all in all, we correlated the outcome at day 5, so in the critical phase, with the neurological outcome, and we saw actually up to 89% agreement with the neurological outcome. Indeed, it's not statistically enough data, but we could already start to see the importance of perfusion in ICU patients. So thank you so much for your attention. Happy to do demonstration or more information. Please contact me.